A patient sits in your chair. They have a skeletal class 2 pattern, meaning their lower jaw is positioned slightly back, a bit of crowding, and a hyperdivergent or long face profile. You bond your brackets, tie in a wire, and plan to tackle the overjet. Following textbook steps for aligning teeth seems perfectly logical here. But by focusing purely on moving teeth front to back and side to side, standard mechanics can trigger a biomechanical domino effect that severely damages the patient's facial proportions. The root cause of this damage comes down to a single microscopic movement. Standard leveling mechanics naturally flex, and as they do, that tension pulls the back molars upwards, extruding them out of the bone. To protect a long-face patient, we have to construct a modified Day 1 treatment plan. The goal is to actively prevent that unwanted molar extrusion, control jaw rotation, and preserve the living soft tissue of the patient's face from the very first appointment. Step 1 is identifying the risk level by looking at the patient's lower anterior facial height, or LAFH. This is the vertical distance from the base of the nose to the bottom of the chin. If this measurement is already long, the patient is hyperdivergent and at high risk. For a short-faced patient with a deep bite, extruding the molars is exactly what you want. But for a hyperdivergent patient, pulling those back teeth out by even 1 or 2 millimeters creates a premature contact point when they bite down. This diagram illustrates the resulting scissor effect. The maxilla and mandible act like a pair of scissors. When the extruded molars make early contact, the mandible is forced to rotate clockwise. It hinges open, moving downward and backward. The first consequence of this downward rotation is immediate. The lower anterior facial height visibly increases. The mechanics are actively making an already long face even longer. Next, we see the soft tissue compensate. With the lower jaw pushed downward, the lips stretch to close, leading to severe strain in the mentalis muscle. Finally, because the mandible rotates downward, the pogonian, the front of the chin, retreats backward. Failing to anticipate this mechanical domino effect leads to a specific damaging outcome. You might successfully fix the patient's bite, but you are actively erasing their chin projection in the process. Now that we know the risks, we have to look at the tools we use on Day 1. A common clinical habit is to immediately tie in a continuous nai-tai arch wire to level out a deep curve of SPI, which is the natural upward sweeping curve of the lower teeth. This diagram shows the underlying physics of that decision. Leveling a deep curve with a continuous wire inherently creates an upward vector. It generates a force that actively pulls the posterior teeth upward and out of the mouth. To neutralize those eruptive forces, the mechanical alternative is to replace the continuous wire with a segmented wire setup, or stepped wires. This isolates the alignment forces and stops the molars from extruding. We also have to adjust how we manage overjet, the horizontal distance between the upper and lower front teeth. The routine use of heavy Class 2 elastics is another major risk factor. This vector diagram of a Class 2 elastic shows why. These elastics span diagonally between the upper and lower arches. That diagonal pull inherently contains a vertical, extrusive force that pulls directly upward on the lower molars. Standard mechanics are designed to align teeth horizontally and sagittally. When applied without vertical modifications in hyperdivergent profiles, those same standard mechanics become actively dangerous. The solution is implementing active vertical hold mechanisms the very second you place your first wire. We need to lock down the molars using preventative appliances. This diagram illustrates a molar secured by a temporary anchorage device, or TAD. Other options like transpalatal arches or Nance appliances serve the same function, locking the tooth firmly into the bone. By securing the back teeth, the anterior teeth can be actively aligned along the arch, while the posterior molars remain completely static in the vertical plane. Implementing this active vertical control transforms a high-risk alignment process into a safe, controlled correction that respects the patient's skeletal pattern. With these modifications in place, the custom treatment plan successfully manages the overjet and the crowding while keeping the soft tissue profile completely intact. It is easy to fall into the illusion of progress. This is the trap of looking at a plaster model on an articulator and assuming that perfectly straight teeth equal a successful treatment. But a plaster model doesn't show the stretching lips, the strained muscles, or the retreating chin. Facial harmony and soft tissue integrity are the true metrics of clinical success. Review your current active cases and look past the articulator. Evaluate the soft tissue and make sure your day one mechanics aren't secretly hinging the patient's jaw open.